Good afternoon, everybody, and thanks for joining us for today's Healthline 3. I'm Jan Elkins. This is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls today, and the doctor will be answering some of your questions live in the studio. Those phone lines are going to be open in just a minute, so let's be sure to give you that number. As a reminder, if you decide to call, we ask that you please make sure you're in a quiet room where you can call with your TV turned all the way down so the echo doesn't happen. Our phone number is 318-219-4569. Again, that's 318-219-4569. And today's topic is all about liver lesions, masses, and cancers. And we have Dr. Zibari with us now in the McDonald Transplant Center. And I appreciate so much you being with us.
It's our pleasure and honor to be here with you.
We've been doing stories for a long time, and you have taken the mantle, so to speak, after Dr. McDonald passed away. And tell me a little bit about the liver itself, and what are liver lesions and what can be done about them?
Well, liver by far is the largest organ in the body. It does process food and toxins, and without not having healthy liver, we potentially could get in deep trouble. So liver have, the way we look at it, having two types of lesions. Some of them are cystic, while others are solid. And cystic lesion, for example, simple liver cyst, cyst adenoma or cyst adenocarcinoma, you have to treat it like malignancy. Liver abscess, amoebic liver abscess, pyogenic liver abscess, those are cystic lesions. On the other hand, there are solid liver lesions. And solid liver lesions, we look at it like benign one versus malignant one.
Right.
So the three most common benign liver lesions are hemangiomas, focal nodular hyperplasia, and hepatic adenoma. Hepatic adenoma is really the bad one, and usually it affected by hormones, females. Potentially it could get very big, it could become malignant, it could rupture. So out of those three, we try to address those hepatic adenoma which become 4.5, 5 centimeters or bigger. It has to be addressed and taken care of it. The other two, only they are symptomatic. And then we look at malignant. Obviously malignant lesion, it could be primary liver cancer, which it starts in the liver, like hepatocellular carcinoma or cholangiocarcinoma, or it could come far away from other organ. And for us surgeons, in large part, we deal with colorectal mets to the liver. It's the most common one. It could be resected, it could be ablated, and again, in the primary setting, HCC with cirrhosis sometimes require liver transplantation because you cannot resect. But we do have ablation modality as well.
So the colorectal cancer moving to the liver, is that because of the proximity of the two together, or is it just the natural process of the cancer itself?
Remember, our liver has a dual blood supply. It gets from the artery and also all this venous blood coming back from the gut, from the liver, small bowel. It all goes through the liver via portal vein. So again, these tumors potentially could spread from colon or small bowel or pancreas to the liver. As I said, it's a very big organ. It is very fertile environment, and clearly cancer can sustain and survive in it very well.
I have heard, and I'm sure Dr. McDonald is the one that taught me, if you didn't, that the liver can be resected. You can cut out a portion of the liver and it can actually regenerate itself. If you have a lesion, is that even possible?
Of course. Liver, many places in the world, they even don't have brain dead donor. What they do, they take half of liver from a family member and they transplant it in the other one.
Wow.
If you watch both livers, both of them would grow back up. It's a very unique organ ability to regenerate and take care of itself, provided is healthy, it's not full of fat, it's not cirrhotic. That's why when we do liver resection, we have to make sure whatever remnant of liver is left is big enough, healthy enough to sustain the person.
Yes. Now you mentioned how if there's not a lot of fat in the liver, we hear a lot sometimes about fatty liver disease. Is that lesions, is that cancer, or is that a third category?
Generally speaking, when you see a liver lesion in a fatty setting, we have to assume cancer until proven otherwise. And unfortunately, as you know, we're trying to compete to be number one in the nation.
Number one in obesity.
Well, that's what I'm saying. And for that reason, at least 20%, 25% liver transplant we do is actually for fatty liver cirrhosis secondary to fatty liver.
Now you also mentioned cirrhosis, and I think most of us are aware that alcohol can contribute to cirrhosis of the liver. But does alcohol contribute to lesions in the liver?
You know, alcohol clearly is a big contributing factor to liver cirrhosis. Also hepatitis B and C, B almost being completely eradicated with vaccination.
Right.
Hep C, for first time, you know, we found a therapy for it. So now in past would have been impossible to cure somebody from Hep C. Now we are able to do it. So cirrhosis, as a rule of thumb, is a risk to develop malignancy in it. So yes, if you get liver cirrhosis, for example, it's more commonly to get liver cancer in face of fatty liver than alcohol cirrhosis, but both settings, yes, are prone to develop liver cancer. And when you get to situation that you have severe underlying liver cirrhosis, you really can't resect. In setting like that, you have to evaluate and assess and consider liver transplantation. And of course, we don't have liver for everyone, and that's why federal government put very rigid criteria for it. For example, if you have 3 lesions, none of them more than 3 centimeters, or if you have 1 lesion, not bigger than 5 centimeters. Every now and then we may have patient who's having 6, 7 centimeters. In setting like that, we could actually ablate it with our interventional radiology by embolization, by putting a heating probe in it, kind of ablate the lesion, downstaging it, so that patient would be qualified to get liver transplant for it.
So just because you have a lesion does not mean that you're qualified to have a transplant, but you can go in and ablate that with either the probe or with radiation, make the tumor smaller to where now the patient is a candidate for transplantation.
That's correct. And also some of those patients may never be able to tolerate liver transplantation.
Right.
So we do have the technology actually now, what we call it histotripsy. A new technology popped up, and this past year Willis Knighton actually kindly got one for us, where we could localize the lesion and we could ablate it by ultrasonic wave to basically do air bubble in it, destroy it, and basically completely destroy the lesion. And so far we have had actually excellent result with 5, 6 patients so far. Long term, all that need to be done, but it appears to be very promising because, as you know, patients don't like to have big needle going through your side of the liver. This does not require no cut, no needle. You can ablate those. That's right.
We have come a long way with technology helping immensely, haven't we?
Absolutely right. I mean, so can you imagine that, taking half of liver out with robot?
No, sir.
Doing kidney transplant with robot, doing Whipple procedure with robot.
It is amazing.
You know, people get back up on their feet faster. They are less wound complication. They can get back to work faster. Less bleeding problems. So overall, it really does help our patients.
So let's talk a little bit about, we obviously know that, as you mentioned, the excessive alcohol can contribute. You mentioned that women and hormones may contribute. Is there another section of the population that is more at risk for developing liver disease?
Well, you know, some of course, if you have people who are having genetic problem. Potentially they could like sclerosing cholangitis, like primary liver cirrhosis. Some of these, what you call it, other genetic related type of
so that
condition.
family history,
family history, genetic predisposition clearly could happen to anyone. But again, if you have hepatitis, and then on top of it you drink as if you are really putting a gasoline on fire, that's how it destroys the liver. That's why both cannot go hand in hand. If you're having very fatty liver, you shouldn't be drinking, for example. So one plus one is not like that. You have to multiply the impact of those pathologies on the organ.
Are you seeing liver disease in younger patients?
Well, of course, we see it. One thing we see nowadays, before was very rare, colorectal cancer in younger generation. And unfortunately, too often, they don't get diagnosed early. And by the time they make a diagnosis, sometimes you have found mets to the liver. So it's a big problem, no doubt about it.
So what are the main symptoms that somebody would notice in liver disease? Are there specific things before it gets to the end result, say?
Unfortunately, too often we see the patient who are actually have very advanced disease. But yes, they could have weight loss, and they could get very easy tired, fatigue. Patient could feel a mass in the abdomen, or somebody, family member could see it, or primary care physician could palpate. A lot of these lesions actually get diagnosed on the imaging done for other indication, unfortunately, but you could get jaundice, depending on where the lesion is and what have you. Get malnourished, you could develop ascites. So there are different symptoms, but yes, you'll be surprised. Sometimes you see a liver so full of tumor, and you look at the patient, does not look like somebody who had actually any cancer. Mm-hmm. That's right.
And we really don't know what causes those lesions?
Well, again, I think that like anything else in the body, we have lead you to do this, do that.
Yes.
There's feedback.
Right.
Like a pituitary tumor of the brain, it tell you to produce thyroid hormone. When you produce thyroid hormone, it'll tell you to shut it down, and adrenal and what have you. So there is a process there for certain, and cancer cells, as a rule of thumb, they really do not take no orders from no one. When the space is very limited and get tight, you would think they would stop not growing more, but here they continue to grow. So it's a bad problem. Clearly, if that feedback is not there to kind of slow down with the growth.
A lot of times we talk about metastatic cancers, which means they travel from one organ to another. What is the process if you have liver cancer?
Well, again, like I told you, liver is a very rich organ, it's a big organ. All blood go to the gut, spleen, pancreas, colon, small bowel, all of it came back through the liver. So if colon cancer get big and large and what have you, it could potentially get into lymphatic drainage, it could get to portal circulation and what have you, and it metastasizes to the liver. So the key element really here is early detection and diagnosis. Like you're having your primary care doc to send you to your GI to do colonoscopy. If they detect a simple polyp there, they snare it, pretty much they curing it. Mm-hmm. However, if you let that polyp sit there for too long, what was actually curable, now it has metastasized to the liver. Unfortunately, whenever you make a diagnosis of colon cancer with liver mets at the same time, long-term prognosis is much worse than those you actually make diagnosis colon cancer now, and 3 years down the road they develop liver mets.
So in March we talked about the fact that it was Colorectal Cancer Awareness Month, and we encouraged people, especially at the age of 40, to go and have a colonoscopy, because you all as GI doctors are seeing younger and younger people diagnosed with colon cancer. So the colonoscopy can save your life from colon cancer, but also from liver cancer, because once that colon cancer develops, it can move into the liver.
Absolutely.
So once the liver cancer develops, can it then move to, like you say, the pancreas, the spleen, the stomach, in that generic area? Can it also move to the brain or to the lung?
Of course, and that's exactly why in 2026 you really have to have what we call it multidisciplinary team. Like every Wednesday afternoon, we meet at cancer center, discuss these patients, you know, with liver cancer, pancreas cancer, kidney cancer, whatever there might be, to discuss it, because it does require multidisciplinary team. For example, giving upfront chemotherapy, the lesion which was not resectable potentially could be downstage, reduce in size, it could become resectable. We have radiation people who meet with us to see if we cannot help them, they can radiate. We are having pathologists, we have interventional radiologists who could embolize some of these lesions, downstage it, and hoping that with chemotherapy reducing in size, going in, maybe then you'd be able to do curative resection. So I think it's very critical, not for me to make a decision alone to say this is what we're going to do, but rather to discuss it with the team, come up with recommendation, and then you'll give those recommendations to the patient and let them decide for themselves what they want to do.
I think too many times people, average person, may say, I just don't want to go to the doctor, I'll do it next year. But what I'm hearing you say, early detection is the key, and it can not only just affect one organ, it may affect several within the body.
Absolutely right. You know, primary care is critical. Do your annual checkup, and too often we'll find a lesion in the adrenal gland, or we'll find it in the kidney, and CAT scan was done to looking at lumbar spine, for example, or looking at chest. So seeing your primary care doctor and kind of doing it is clearly important. I'll tell you a small example. I went to see my primary care doc because of my age and everything else. He wanted to get CT of chest, and I never argue with him. And had calcium in it, in the vessel. That led to arteriogram. Before I knew it, I had a bypass done. 3 days later, I went back home. And 3 weeks later, back at work, operating again. But if I would have a major MI, then I may never make it to the hospital. And the reason is because my primary care doctor felt this one need to be done even though I had no symptoms. So I think it's critical to visit your primary care doc and do your annual checkup, being mammography, being colonoscopy, whatever there might be, or blood test, hoping to detect this problem and being able to intervene in a timely fashion.
So you just gave us a great example of a physician who, instead of physician heal thyself, you're taking your own advice, going to your own doctor just for a routine checkup.
That's correct.
Because they may find something else. And again, we just can't emphasize that enough. Sometimes it may be a life or death issue, and there are so many things that can happen in the body.
Absolutely right.
So when we talk about transplantation, but especially liver transplants, and we talk about taking the anti-rejection medications, are those always the same if you do a transplant, no matter what the cause of the transplant was?
As a rule of thumb, we have about 2-3 drugs is given to all transplant patients. However, for example, liver is much more tolerogenic. It adapts to the body much better than kidney, pancreas, heart, or small bowel. And it also depends how young the patient is. The younger one require more anti-rejection medicine. Older one will require less. And we adjusted medicine as we go forward. A lot of these patients, liver-wise, only taking one agent. 20 years out,
That's
doing
amazing.
extremely well, only
Isn't
taking
that
one
amazing?
agent. Absolutely right. Yeah.
Wow, I'm impressed with that. So when we talk about the benign lesions, What treatment options do you give there?
You know, again, like I said, if you have a benign lesion, have no symptoms, we really don't mess with them at all. We'll follow up. If it doesn't increase in size, we leave it alone. Now, except for hepatic adenoma, as I said, is most common in female. It usually relates to their hormones. It potentially can escalate in size. They are potential to actually rupture and bleed, and also the incidence of malignancy in that subset of patient is much higher than the other two lesions. So situation like that, we recommend something need be done. Clearly, nowadays we could do robotic or laparoscopic resection. We could ablate this lesion with microwave, with radiofrequency ablation. This new technology came out, histotripsy. We could ablate these lesions and monitor without actually needing a major surgery. So, but we do follow up those patients. In past, anybody who's having a lesion 5 centimeter hemangioma, we would label it as giant hemangioma and we would operate on. No longer that stand, and it's not really necessary. So we don't mess with those unless patient is a policeman or woman,
Right.
a sport, contact sport, football.
Yes.
You racing horses, you traveling abroad, you have no access to the health care. In setting like that, those hemangiomas should be considered for resection. Otherwise, we just don't mess with them.
But if there is a lesion or a mass, and I'm using a big ball and that's not accurate, it's much smaller than that, it has a better potential to grow into something else than if someone doesn't have a lesion at all. Am I right?
That's right, especially hepatic adenomas.
Right.
Well, I mean.
You mentioned traveling overseas. We are so blessed in this country with the great medical care, and specifically in Shreveport to have the care that we have and what you all provide at the transplant clinic, aren't we?
You know, no doubt about it. Often I say that when I see a patient with liver cancer, pancreas cancer, needing transplantation, I feel horrible for them. But at the same time, I give them the bright side. I just came back from Zambia, for example, doing kidney transplant. They're trying to teach them how to do it.
Yes.
They have no technology. They don't have chemotherapy. They have no. So you see these children, yellow jaundice. You know, with the transplant, they can be fixed. Or patient with big pancreatic cancer could be resected, taken care of it, or given chemotherapy. They have no access to it. So at least in this country, we are blessed to be able to have access to the health care we have. So no doubt about it, what we discard here in America, for them is a brand new technology. In fact, in Zambia, I had to put 2 sets of technology, laparoscope, owned by 2 separate private guys, to make one so that we could teach them how to take a kidney out laparoscopically. The hospital, the biggest hospital in the nation, didn't have a laparoscopic set.
Wow.
So again, we clearly are very blessed. Willis Knighton has 12 robots. LSU has several of those robots. And again, it's God's blessing. Champaign, same way. So we're having a quality care health system in our community.
And you mentioned that last year Willis Knighton purchased a machine that helps you all in your diagnosis and therefore in the appropriate treatment.
Absolutely right. I remember in '93 when I came back, I went to Dr. McDonald. I said, I want cryosurgery. Cryosurgery, you freeze the cancer. And we asked, and they did their homework. They said, we know this would make money for the hospital. We have no money to get it. I said, so is it okay for me to approach Mr. Elrod? They said, we have no problem at all. I went to Elrod. I tell you, just like this, he purchased our first cryosurgery ablation technology in this region. And that what really brought in too many patients, otherwise we would not have seen. If it had not been because of cryo, it was actually resectable, but primary care felt it's not resectable, so they would never send to us, and those could not be resected.
Right.
Were ablated.
But we are so grateful for you and what you have done in this community. And you have a doctor who has been in this community for a long, long time, offering us expert advice and opinion. And in fact, Patricia is on the phone, good doctor. So Patricia, go ahead and ask your question.
Well, Hello, Doctor. I'm so happy to hear your voice and to see you. You did my surgery back in 2024, and I want everybody to know what a wonderful physician you are. You were very encouraging. You were very informative, and we are just so fortunate to have you here in this area. Remember, you removed a hemangioma for me during the holidays. And I just want you to know, and I love to see your face on here. I wanted to say hello when you had one new colleague to come in from, I believe it was Arkansas. She became a part of your team. But it's just wonderful to see you.
Thank you very much. I'm very happy that you've done well, and it clearly is our honor when a patient entrusts us with their life. Of course, we all are in God's hand, but nothing makes me feel better when patients trust us to take care of them. And I've made commitment that we treat our patient like our family, so that's the only way to practice medicine. Thank you for your call.
Patricia, thank you for your kind comments. We appreciate that so much. And Doctor, I'm so proud of you because you came in, Dr. McDonald was already doing transplantation, and at the time it was very new in our area. He perfected it. You came in and helped him, and it's been amazing what the two of you and now you are actually doing.
I'll tell you that this is not one or two individual deal. Dr. McDonald brought us all up. He guided us, he mentored us, he made sure that we would do the right thing for our patient. But remember that Transplant Center as well as Advanced Surgery Center, both are full of very able employees and colleagues, and only together through multidisciplinary approach we can make an impact. You know, we rely on our anesthesiologists and critical care and nursing personnel. It really, you have to have all pieces in place in order to be able to make an impact.
And you are so humble, but it does require a large team, doesn't it?
Absolutely right. You have to have it.
I was blessed, not with these surgeons, but with Dr. Masin Hakim, who was a heart transplant surgeon, to fly with him to South Louisiana, retrieve a heart in a 14-year-old person, came back and put it in a 59-year-old man that I'd been doing stories on, and watched that man get a brand new heart and a new lease on life. But several of you had been working with the transplantation, working with the transplant clinic to grow it, to improve it, and to let people know that it's even here.
You know, I think having a major medical condition like malignancy or needing organ transplant, that puts so much burden on the patient's mind and their families. And traveling far distances clearly will add much more to it. So the community done very well to provide these services to make sure our patient will not need to travel far distances. So we are blessed to get the necessary support from our team, from our leadership, from our hospital and our community.
Now, with liver, you can resect it and it may grow back, but not so with some of the other organs. So let's speak to the fact for just a moment as we close, the importance of signing up for being an organ donor.
I have in my driver license, I have signed, I've told my family and my kids, you know, I want to be an organ donor. If I depart from this world, I hope I would touch other people's life and save other people's life. I remember very vividly, we were at LSU. There were two patients at the pediatric intensive care unit. One of them from Nigeria, 6-year-old kid on dialysis, on breathing machine at verge of dying. Across from her, there was this little Caucasian girl, like a doll, became brain dead. The family came forward, said, "Doc, we're going to donate her organ under one condition. We want her liver to go to this child."
What a blessing.
And I tell you, that child went back to Grambling and graduated and became their IT department head. And if it would not been because of that family's gift of life, that child in 24 hours probably would not have made it.
Bless your heart. Well, you certainly are giving the gift of life, and we're so grateful for you being on today, but also what you do every single day. Thank you, Doctor, for being with us. And just a reminder, it is very important that we all sign on our driver's license that we do want to be an organ donor if we do leave this world. but also it is just as important that you talk with your family or your friends, whomever is going to be at the end of your life standing around your bed. Make sure that they know your wishes as well. For all of us here at KTBS 3, thank you for joining us for Healthline 3.